Good afternoon and welcome to the WAVY Digital Desk. I'm your host, Sarah Good. Today we're going to be talking about IVF in Virginia. We're speaking with a local clinic right here in Virginia Beach that has been open for about 30 years. We're going to be speaking with Dr. Robin Poe-Ziegler from CCRM Fertility in Virginia Beach. And I want to talk about why this is so relevant. So yesterday, both chambers of the Alabama legislature approved bills to protect IVF. Now, this comes after the state Supreme Court decision that said that embryos can be considered children under the state law. Now, the legislature voted to approve legal protections for the practices providing IVF, so they don't need to pause treatments. But this has become sort of a relevant national conversation, and I just wanted to localize it here in Virginia and talk about with local providers, what IVF is for the community and for viewers out there. Hi, Dr. Robin. Thank you so much for tuning in with us today.
Hi, thank you for having me.
Absolutely. And you've talked to WAVY before about your clinic, but can you just tell us a little bit about how long it's been open, how long you've been in practice?
Yes, well, actually on Tuesday, this past Tuesday, February 27th, it was 27 years ago that I had opened the practice. The practice had been opened under the name of the New Hope Center for Reproductive Medicine. And then about a year ago, I joined with Colorado Center for Reproductive Medicine, and now we're the Colorado Center for Reproductive Medicine Center here in Virginia Beach.
Great. And, I know that you've been here in the community. I'm sure you've worked with many different, women and families across that time. I mean, do you have any idea how many babies have been born? Do you keep track of things like that?
Yes. So here at my center, we've assisted in over 4,000 live
Wow.
births in that last 30 years or
And
27 years, I
yeah,
should
sorry,
say.
I said 30. I jumped ahead, but about 30. And first I wanted to ask for women and families that are coming to you, I mean, where does the visit start? Do most people come in after they've tried a lot of different fertility treatments and this is sort of their last, efforting? Or, I mean, where do people come on the spectrum? Do they come earlier to see, what the fertility situation is? Can you just talk a little bit for first-time patients, what that looks like?
Sure. Well, usually I'm seeing patients that are coming at all different times. The way that the OBGYN is usually counseling their patients is that if you're under 35, you should probably try for about a year. And if you're unsuccessful after a year, then you should seek further assistance from a reproductive specialist. If you're 35 years old, they usually are recommending that you don't try longer than for 6 months before you seek more professional investigation. Now, some of my patients, even though they may be younger than 35, may have special conditions that they've been diagnosed with, such as tubal disease or endometriosis. Those types of patients already have been given kind of an alert that they may have more difficulties conceiving. So they don't typically wait a full year, even though they're under 35, before they seek assistance because they already are at a higher risk for having a problem. But I see patients coming, as early as young as 19, and as old as I'd say 59 years old
Well,
has been my oldest patient.
okay. And, that is quite the spectrum. And I think when people think of IVF, at least right now, I think they do sometimes think of, women that either have difficulties or that are later in life, that are trying to have a family. But really, it is that full spectrum, as you just said.
It definitely is. And especially in younger women that have had chlamydia or gonorrhea, they've had pelvic inflammatory disease. Those things damage the fallopian tubes greatly. And so, those are patients as well that would need in vitro fertilization. If the tubes have been damaged and subsequently removed, their only course by which they could be able to have a biological child would be to use IVF.
And, I just want to talk about, I think, mentioning even just having this conversation with you today, so many people either know people that have had IVF or they themselves have used it. I mean, the toll seems to it seems to be a difficult road for some, you know, in terms of maybe emotionally, financially, and physically. Can you first just talk a little bit about, you know, the emotional side of it that you've seen with patients, that they're coming to you sort of with this hope that this will work?
Yeah. Um, In vitro fertilization is a wonderful technology, but it is an expensive technology. There are many patients that don't have insurance coverage for it. That makes them even more anxious, especially, you know, what if we do all this, we pay all this money and this doesn't work? Their patients come here, some of them are needle phobic, and these patients do need to use injectable medications so that we can stimulate their ovaries to mature more than just one egg as they would in a natural cycle. We would like to get maybe 10 or 15 eggs if possible. So they have that. Uh, Many of them have a fear of needles. Every time they come into the center for a follicular tracking ultrasound, when they're using their IVF stimulation drugs, they're having to have their blood drawn so that we can check their estradiol level. So, you know, they're getting stuck a lot. It's physically draining on them. They're trying to find time in their busy lives and in their work schedules to make the time to come in and have their appointments. And then on the day of their egg retrieval, that's going to be a day that they're not going to be able to work. They have to come in having had nothing to eat or drink after midnight the night before. They have to have an IV placed at that time. They undergo anesthetic agents so that they can be asleep for the actual egg retrieval. And then they're usually kept here with us for a couple hours after the procedure just to make sure they're doing fine. They're waking up, have to have a family member take them home and stay with them for the rest of the day. So there's a lot of time investment. There's, you know, the physical investment that they have to kind of get themselves up and, you know, in the mindset of, okay, I'm going to be using all these injections, but it's going to be worth it. And, you know, and thank God with the advancements that we have, especially in the younger women, you know, most of the cycles are successful. But there are always times where the cycles are not successful. And, you know, and an unsuccessful cycle can mean where they may not get any embryos at all, that nothing would fertilize, or perhaps they are doing genetic screening on their embryos, and perhaps none of the embryos are chromosomally normal. They may not get to even have an embryo transfer in those cases. Or they may do a transfer, the embryo may not implant, and that's an unsuccessful cycle. Sometimes the embryo does implant and things start growing and we think everything is going well, and then suddenly their beta HCG level falls and they experience what's called a biochemical pregnancy. And that is just as devastating to these patients as if they had gotten to 6 or 8 weeks and, you know, and didn't have fetal heart motion, or if they got closer to the end of the first trimester and miscarried. So it's really a roller coaster, and I tell all my patients that, and I try to have them as informed and as protected, and I try to strap them in as tightly as possible before I put them on that roller coaster ride, because there are so many ups and downs that go along with an IVF cycle. It is certainly not for faint of heart patients. They really do need to psych themselves up. They need a good support system. Myself and my team here at the center, we're like their second family, you know, and we try to cheer them on. All my patients are given my personal cell number so that they can contact me at any time if they have any questions, or if they couldn't get in touch with a nurse, so that they just don't feel like they're in this alone, because this is one of the the biggest things that they're probably ever going to do, besides buying a house or, getting married, or it's a really big thing to go through, and they need a good support system. Many of my patients, when the cycles are not successful for whatever reason, they 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 feel broken. They feel like there is something wrong with them, that it's their body's fault. It's their body is not working the way it should, the way that other women's bodies work. And, it's, they just have so many obstacles to overcome. Of course, other people in their lives are getting pregnant while they're not getting pregnant. They have the emotional agony of trying to pretend that they're happy for someone else who is getting pregnant while they're also being very sad that they're not getting pregnant. So it's a difficult journey for the patients that are experiencing infertility.
And, I just to connect to sort of what's happening nationally, I guess with how grueling the process can be for some and how heartbreaking it can be, how important is it for IVF to be protected for the families that are going through it? It's obviously not an easy decision for these families to sort of have to go through IVF. So, if they feel like the rug could just, get pulled out from underneath them, I mean, how important is it to have it stabilized?
Oh, I think it's critically important. And I know that everyone, all my colleagues in this field, feel the same way. We feel that, everyone should have the right to be able to build their family. And for so many people, one out of every five women in the United States are suffering from some degree of infertility. And to not be able to access the full spectrum of what is scientifically available to these patients these days, is in my opinion just absurd. It just does not seem right.
And have you had conversations? Maybe this has been something that's happened for years. Talking about as a provider what maybe legislation you would like, or what support from the government does that, or have you really not had to think about that much because this has been such a practice for so many decades at this point?
Yeah. And basically, I guess, I had the very unique opportunity of being trained by Doctors Howard and Georgiana Jones back in the 90s when, they were, relatively, newly coming to the Norfolk area to the Jones Institute. And of course, I sort of grew up in the time frame where there was a lot going on. There was a lot of research. This was an up and coming subspecialty. And so much has been accomplished in the last 40 years. The thing that I've really had to talk with my patients mostly about has not been the legalities of this, but more so the financial aspect. And it has seemed that for so many years that most of the insurance companies have not been supportive of this type of therapy for the patients. And so I would say, back in 1997, when I opened this practice, it was very uncommon to have a patient that had insurance coverage for any type of infertility treatment, whether that would be something as easy as clomiphene citrate and an intrauterine insemination of their spouse's sperm, all the way up to IVF. Most of those procedures were not covered by insurance. It's only been within the last few years that we've really seen kind of an insurgence of the insurance companies and the employers bringing on products for their employees now that do give them benefits for these procedures, and are now opening up this field and allowing access to so many patients from a financial standpoint that were kind of cut off from it before. And now that, the the legal system is seeming to try to get involved at this point, when it finally seemed like, things were going well and going in favor of the infertile patients, it was just mind-boggling when, when the Supreme Court decision came out in Alabama 2 weeks ago. We were all very, very shocked by that.
And in
Um,
terms of access too, I imagine for some people, I think there's 11 practices, at least according to the CDC in Virginia, that offer IVF services. So there are going to be places throughout the country and in Virginia where access to an IVF clinic is difficult, right?
yes, yes, absolutely. I mean, two of my patients earlier today drove over 4 hours to get
Wow.
here. And so yeah, I we see that on a daily basis. It's not everyone is as lucky as the population here in Hampton Roads, where we have two or three centers here that are very local and easy to access, but that's not the case for many people, even in this state.
And even in this area too, I mean, the recognition of IVF treatments in general, I mean, it has been so present in this region for so long. I feel like that has to make a difference too with people maybe knowing or understanding what it is, but also maybe that community support.
Yeah, definitely. I mean, because again, doctors Howard and Georgiana Jones had moved into Norfolk in 1978, when they left Johns Hopkins up in Baltimore, and within 3 years they were able to have the first IVF baby in this country. So very much has happened here, in the Hampton Roads area, and we had such a unique opportunity to have those two, pioneers in our community. So yes, I think that our local population does know a lot more about IVF than many other places, perhaps.
And I wanted to ask you, the decision to have IVF, I think some people, just maybe out of curiosity ask, there are so many other options. I think just maybe, I don't know if that's what critics say, but, is out there, whether it's adoption or other things, but the personal choice to be able to do IVF and have this ability, I mean, have you heard from patients about, having to make that decision, or maybe they've tried IVF so many times and it's just not taking? I mean, what is that piece of it like, sort of going through your options?
Yeah. So basically, when the patient firstly comes, we get a very good uh, historical account of what they've been through, what diagnoses have already been rendered. If this is a basic infertility patient, then obviously we start from a basic workup. We check their fallopian tubes, we check their egg reserve, we check the husband's sperm count. But many of the patients have already been at other centers. They've already done, you know, um, kind of lower level infertility treatments like clomiphene citrate, like intrauterine inseminations. And so when those things have not been successful, is typically when they are then being faced with needing a more interventional type of therapy, such as IVF. Um, there are patients that come that are in their late 40s, and many infertility centers do have age limitations at this point, where we haven't seen that there are viable pregnancies coming from eggs that are maybe 48, 49, 50 years old. And so we have the ability to at least assist those patients if it's a feasible option for them to use eggs from a younger woman that may kind of phenotypically match them, may be their same ethnic group, hair color, eye color, and we use their husband's sperm to inject those donor eggs and then put those embryos in the wife's uterus. Sometimes, the couple come in and she's older, she doesn't have eggs, he has issues with sperm, and sometimes we end up using donated embryos from couples that have already done IVF cycles or donor egg cycles, where they've had extra embryos that they've frozen with the initial intention of using them for their own family building. But something has happened along the way. Many times they have gotten all the children that they want, and they may still have some embryos remaining. They're faced with a difficult decision at that point as well. What do we do with these embryos that are still in the freezer? And so many of our patients will donate the embryos to the center. We then are able to donate those embryos to the couples that perhaps that's their only way of proceeding. And certainly from a financial standpoint, that's also very helpful to them because they do not pay for the embryos. And then there are some patients that, you know, the woman comes in, she had uterine fibroids, she needed to have a hysterectomy. So now she doesn't have a uterus to be able to carry a baby, even if we can use her own eggs. So we're doing gestational carriership, where we will find women who have been very successful in having pregnancies and want to help other women achieve that. So we'll use gestational carriers in that case. Um, but you know, there are so many options, especially because of all the assisted reproductive technologies and all the work that all our predecessors have done in the last 40 to 50 years. So it's uncommon that a patient or a couple come to me where there isn't an option, where there isn't something that is, you know, a feasible option for them.
And I just want to show a little bit of footage of, what some of these, I guess, tools, but also, storage things look like. Some of this footage actually might be from the New Hope office, and so you'll see that as well. But just if
Yes.
people aren't familiar, sort of what it looks like behind the scenes. But I did want to ask too. It seems, if you have embryos that you're able to successfully have in the first, maybe course of IVF, that seems to be lucky, or it fits well. But there are embryos obviously that you could go through all your embryos, correct? In the course of IVF trials. So I mean, what do you make of that? I guess people are curious right now, obviously, about the embryos in storage, and that's sort of what the Alabama case was about. But you're lucky, really, if you don't have to use all your embryos, and it does
Yeah.
take on the first try.
Yeah. And I think that, you know, in the early, I guess it was the early 90s that they started doing genetic screening on embryos, that allowed us to identify when an embryo is chromosomally normal and when an embryo is not chromosomally normal. Up until that point, we would just sort of from a morphological standpoint, how good the embryo looked under the microscope, we would we felt we had a sense of whether this was going to be a good embryo and had a good chance of implanting, and we thought that that would end up coming out as a healthy baby. And when the genetic aspects became available, we were very shocked to see that so many of what appeared to be beautiful embryos and the highest graded embryos were actually the most chromosomally abnormal. So what we've been able to do because of the genetic testing, is we can now identify the chromosomally normal embryo and therefore only transfer a single embryo. Whereas before, when we couldn't test the embryo, a lot of times we were putting back more than one embryo, maybe two or three embryos, because we didn't know if any of them were normal. We didn't know if any of them would implant. And unfortunately, what was happening is that we were getting a lot of what are called higher order multiple gestations. So twins, triplets, quadruplets, the octuplet pregnancy that many years ago was very well known, occurred by transferring of multiple embryos. And so I think that the genetic aspect has allowed us to, when an embryo is genetically abnormal, the patient is able to discard that embryo, not keep it in storage, because we know that that would not either implant or result in a healthy outcome. So that's been able to decrease the amount of embryos that are kept in storage. It's been able to help us to get to the point where we can select only one embryo for transfer and therefore decrease the market risks that are going to be presented to the wife, the woman, and the babies of, the twin or triplet pregnancy where the babies are trying to share the space and oxygen and nutrients that really should all just be for them as a singleton rather than sharing it among two or three or four of them.
Wow, and that's
So,
interesting. I mean, how much science has progressed that now obviously you're able to see that health. That makes me curious, is there anything that you all are seeing coming down the line or any new technologies or things that have been helpful or that you hope will be helpful in the future?
oh wow, there are so many things that they're constantly looking at. I think some of the newer things that they're hoping for would be that we wouldn't have to do actual biopsies on the embryos, that we wouldn't need to take a little piece of the embryo, that some of the excrements of from the embryo and things that we're finding in the culture media of the metabolism of the embryo is releasing, that we might be able to find kind of clues and information about the embryo so that we wouldn't need to do an interventional procedure on the embryo. So that's one of the things I know that they're looking at. There have been so many things recently. I think that more recently the new freezing technology that has been developed with vitrification, the flash freeze, um, has allowed us to now freeze eggs, when before we could only really reliably freeze embryos. We've been able to freeze sperm for many, many years, but the egg is a very fragile cell. And so when we were using the technology from the early 90s, the slow freezing technology, only about maybe 20% or so of the eggs that we would freeze were able to survive a thawing process. So at that time, egg freezing wasn't clinically available. We would only do it on women that were diagnosed with some form of a cancer, that needed to undergo chemotherapy treatments or radiation treatments. So we would say, well, what the heck? Let's just put some of the eggs in the freezer, and hopefully when the woman beats the cancer and is healthy again, hopefully at least one or two of them will survive the thawing process. But now with vitrification, we have over a 90-95% survival rate with eggs, just the unfertilized egg alone. And so I think that's been one of the huge developments, along with all the genetic testing that we've been able to do on embryos. And I just foresee that there's just going to be more and more, as long as, we in the scientific world are allowed and not legally restrained from doing testing to help progress and further the field of assisted reproductive technologies.
Right. I mean, you're hearing too, so many businesses, as you said before with IVF, are offering services for freezing eggs and offering
Yes.
resources for that.
Yes, it's so wonderful. I mean, and especially too, with young women that are going into a career that's going to take them down a lengthy training process. Someone like myself who, I mean, by the time you go to college and medical school, and then you do a residency, and then you do a fellowship, I personally found myself to be 37 years old and still had not had the opportunity to even think about trying to conceive myself. And so women in medicine, women in law, women in general, I think it's wonderful to be able to offer them the opportunity to freeze eggs now while they're young, while they're not interested, and it's not the right time for them to be having children because of what their career goals are. And then later on, when they come back, like so many of my patients in their early 40s, when they're in their 40s, what we know, the egg as it ages is going to have a higher risk of forming a chromosomally abnormal embryo. So by the time a woman gets into her, 42 years old, it's estimated that over 80% of her embryos that are generated from her 42-year-old eggs are going to be chromosomally abnormal. So this would be a wonderful opportunity for young women to freeze eggs, to preserve their fertility for later on when it is the right time for them.
Wow. And I mean, even just you saying the stats of 20 to 75% gives you so much hope for that as well.
Yeah, yeah, exactly.
Well, Dr. Robin, thank you so much for speaking with me today. We're about out of time, and I know that you have patients that you are going to be seeing. But thank you so much for speaking with me about some of the legal situations that we're in right now, how important
Yes.
IVF treatments are for women and families, and giving that option. It's just been so interesting to hear about, and hopefully someone watching this answers some questions. The last thing I wanted to ask before we're
Yes.
ending is just, what would you want women to know, leaving this conversation, if they're on their own journey, in terms of what to do?
The best advice I can give to anyone is, to go sooner rather than later. You're never too young to come to an infertility doctor. Even if it's just to get information. If you have the opportunity to freeze eggs when you are young, I certainly highly encourage that. And don't ever be afraid. If this is something that is really a conviction on your heart that you want to be a mom, don't let anybody or anything keep you from pursuing that. I just feel really strongly about that, even though I only have one child. He is the highlight of my life. He's more than any degree that I have. He's everything to me, and that's why I've been so passionate about this field and the last 27 years here at the center. Is I really, really just want to help every woman that wants to be a mom to feel the way I do and to know what that is really about, because that for me is really what life's about.
Well, thank
Thank
you.
you for having me.
No, thank you. I was just going to say, that is such passion that you said in your answer. So I think that's a perfect place to leave it, with that women know that they have options, and they have options right here. If you are local in Hampton Roads, I think it is incredible that, as Dr. Urban said, with, people traveling hours to see her, how lucky we are to have services in this area for those who need it. But Dr. Robin, thank you so much again for speaking with me today.
You're so welcome. Thank you. Thank you.